Hello, and welcome to the Dr. TOOMER Talks Show. I'm Dr. Catherine Toomer, family medicine and community health physician, and founder of Total Weight Care Institute. And I wanted to talk today. I get a lot of questions about what labs should I get. I hear a lot of information. So what I'm going to talk about today are the labs you can ask your physicians for, because sometimes the best care is the care that you ask for. And so I'm going to talk today about what tests you can ask for what things you may be worried about, and also what not to ask for, because there's some labs that people have been convinced that they need, and it's a waste of their time and their resources. And so there are other ways of getting to the answer, and I'll talk about that at the end. But specifically at the end, talking about the labs that you can get when you're starting to have weight gain and you can't seem to figure out how to get rid of it, or it's more difficult to lose weight than before. Often it's related to insulin resistance and cortisol. So I'll talk about the testing that can happen at the end, because that's often the most important one that people want to hear. So before we get started, I'm going to say hello to people here. Hello, Marcia. Hello, Cindy. It's great seeing you guys. Thank you for coming. So now I'm looking at my Wi-Fi. For some reason, it seems to be a little unstable. Again, if I go away, come back, I'm getting that worked on, got the cable company coming. But if I do tend to get disconnected, I will come right back. So number one, I'm going to go through 9 of them. Well, 10 altogether. So if you have a pencil and paper, you can write this down. And if not, tell me where you're listening from now, introduce yourself, or put in hashtag replay if you're watching later, and let me know where you're listening from there. Because I always like to know. It's kind of nice to see where everybody's coming from. So number 1, overall health, and specifically bone health. Checking vitamin D. Now, vitamin D helps our body make bone. It helps us absorb calcium, and calcium is used in a lot of places in the body, in muscle contraction, including our heart, but specifically in bone absorption or bone making, I guess, building. So in order to have healthy bones, vitamin D levels are very important. When your vitamin D levels are low, however, it can cause a lot of achiness, a lot of fatigue, some skin changes. If it happens in children when they're very, very young, it causes bowed legs, or what we call rickets. And so vitamin D is a very important. And the beautiful thing about vitamin D is it's easy to replace. It's easy to check for. And these are all blood tests, by the way. So it's easy to check for, and it's easy to replace. So Tammy's asking, what is the highest safe level of vitamin D to take? It really depends on the level of what you need. However, the prescription strength is 50,000 IUs, or international units, once a week. And so and usually over the counter, it's about 7,000 IUs over the counter. And so you can take, if you're deficient, it really isn't a high number, but you just want to kind of stick to the prescription strength. I usually kind of advise that. But again, know if you're low, because this is the thing with vitamin D. It is a fat-soluble vitamin. So if you go too high, it can cause you problems with kidney stones. So you start over-absorbing calcium, and then it becomes kidney stones. So you want to make sure that you actually need vitamin D. However, most of us do, because the only other way to get vitamin D besides taking a supplement is through the sun. And many of us do not spend a lot of time in the sun, because now we know that the sun is dangerous and UV rays can cause skin cancer. So even sunscreen can help prevent the body's ability to make vitamin D. So the safest is the prescription strength. And so 67, you want your that seems a little high, but if you want it to be over 30. So that's where the range is. And then what I'll do at the end is I'll answer more questions at the end. So number 1, vitamin D. Number 2, thyroid disease. If you think you may have thyroid disease, you're gaining weight, you're getting puffy around the face, You're very, very tired all the time. Your skin's getting dry. Your hair's getting brittle. You're losing your eyebrows. And you suspect you might have thyroid disease of some type. The first thing we check is a TSH, thyroid stimulating hormone. And what we're looking for is to see if it's high. Now, that's the first thing we check. Then, if that's abnormal, this is what normally happens, but some doctors jump right to a thyroid panel. And what a thyroid panel has is shows all the different levels of thyroid, TSH, thyroid stimulating, but also the actual thyroid hormones themselves, T3, T4. And so that gets checked, and then look at those levels. Often, though, if those levels are off and we're trying to figure out why they're off, we may check thyroid antibodies, because there can be antibodies against the thyroid hormone that will drop your thyroid hormone and make your body act like you're hypothyroid. And it's not because of the TSH or thyroid issue, it's something attacking the actual hormone itself. And then the one more commonly used is relatively newer way of checking for thyroid disease, because you can have all those normal, but if you check reverse T3, that can actually be the culprit. And so usually that's down the line. Usually those are endocrinologists who test for that, because it's usually not something that's normally done with your primary care doctor, unless they're really, really well versed in thyroid disease. But usually we leave that up to the endocrinologist. So in number 3, when checking for heart disease, what we're doing is we're checking for your risk factors. How much of a risk are you at having an adverse cardiac event? And which primarily what most people think about are myocardial infarction, or MI, or heart attack. And so what we do is we check for cholesterol, because many times what that is, it's cholesterol that sticks to the inside of our blood vessels that cause plaques, and those plaques can break. And when they do, they cause a clot, and they make it so that blood doesn't get to the heart. That is what a heart attack is. And so we check cholesterol levels. We check a cholesterol panel, and what a cholesterol panel usually has is your total cholesterol, your LDL, which is what's considered your bad cholesterol, your HDL, which is considered your good cholesterol, and your triglycerides. There's a few others thrown in. There's the other ratios and other stuff thrown in, but those are the 4 main ones that we look at. But one of the tests that we encourage people to get to indicate their risk factors, even in the face of normal cholesterol, is lipoprotein A. It is genetically passed along, and it does indicate a risk factor for heart disease. Even when everything else is normal, if your lipoprotein A is abnormally high, it can put you at risk for heart disease, heart attacks. The other we check for is HSCRP. What that stands for is high sensitivity C-reactive protein. What that is specifically checking for inflammation. It's not very specific, but when it's high in the face of other things and other symptoms, get very concerned, because we know that heart attacks, heart disease, blood vessel disease are an inflammatory process. And so we look for that to see if there's any inflammation. And then the last is homocysteine levels. We want to see if those are high. That's an amino acid that essentially is given up from damaged heart muscle. And so we want to look for that. Number 4, another subset of heart disease is hypertension. It's a type of cardiovascular disease that can lead to problems down the road. One of the main things we look for with hypertension is kidney damage. You want to make sure that your kidney function is normal. You can get hypertension just from kidney failure, or kidney insufficiency, or renal insufficiency. And so we check what's called a complete metabolic panel. And what that does is it tells us your blood sugar, it tells us your sodium, your salt, your calcium, your potassium, but it also tells us your liver function, and more specifically, your kidney function. And that is what we're looking for when we are looking at checking someone who already has hypertension. Another subset of heart disease is congestive heart failure. This is number 5. Congestive heart failure is usually it's of 2 types, but the one that's most commonly seen is when the heart muscle stretches, it gets loose. And when that happens, there is a substance that's given off, and it's called BNP, brain natriuretic peptide, but most people just call it BNP. That is elevated when you're in congestive heart failure. Now, there are some instances where it's cleared in the kidneys, and if the kidneys aren't functioning properly, it can elevate, falsely giving the impression that there's something wrong with the heart. But for the most part, we still look for it to see if it's there if we suspect congestive heart failure. Of course, with congestive heart failure, we also do other testing like an echocardiogram, but I'm talking about blood tests specifically today. If we suspect, number 6, prostate disease, we check a PSA. We encourage all men over 40 to start getting PSAs. Anyone who's having difficulty urinating, anyone who's having difficulty with their urine stream in men, we check a PSA. And that's prostate, I just forgot what the S stood for. Prostate antigen. And oh goodness, I just forgot what the S stands for, and that just happens sometimes. All right, sorry about that. Someone can look it up and post it in the chat. And number 7, again, for men, if they have erectile dysfunction and low libido, or women, if you have really low libido, which often happens right around menopause, is checking for testosterone. It is a misconception that women don't have testosterone. We actually have more testosterone than we do estrogen. We just don't have as much testosterone as men have. So when our testosterone drops, we lose interest in sex. And that can cause a lot of problems in relationships. In men, when their testosterone drops, they also lose interest in sex, but they also lose the ability to have sex because they have erectile dysfunction. So if any of those things are happening, checking a testosterone is very important. And then number 8, this is key because this is the one that causes a lot of people issues when they don't know it. It can be insidious, it can be there, and people just don't know. They're suffering through all the symptoms of, fatigue after eating, of urinating all the time, being thirsty all the time, gaining weight, especially through the middle, and not understanding why. What it could be is type 2 diabetes. And to check for type 2 diabetes, we check an A1C. Now, many times doctor will also check a glucose level, but they often check a fasting glucose level. Fasting glucose really can be normal even if you have diabetes. And so I personally prefer to check those labs after someone's eaten. Now, glucose goes up and down with each meal. A1C is an average. So you can actually, so when it's high, what that means is your blood sugars are running high for most of the past 3 months. And that is what how we diagnose diabetes. We can diagnose diabetes with a fasting blood sugar if it's over 140 and on 3 different occasions. But for the most part, we check an A1C, and an A1C over 6.5 is considered diabetes. Yes. Thank you, Cindy. Prostate specific antigen. Why I blanked on that, I do not know. But anyway. And then number 9, this is the one that really is causing us so many issues. Insulin resistance. Now, that has been thrown around a lot lately, mainly because we understand this is a metabolic dysregulation that often goes undetected, it goes unchecked, and it causes a lot of weight gain. It is the one of the primary reasons that we have obesity. It causes very easy fat production from very few calories. And so checking for insulin resistance, particularly when you're having some of the symptoms of diabetes, but you don't quite have diabetes, or you have an A1C that's under 5.7. 5.7 to 6.4 is considered prediabetes. And so you can have insulin resistance with a normal A1C below a 5.6. And so what it does is that you have blood sugar spikes that, one, cause all sorts of issues with fat production, but the insulin resistance means that the brain's not getting the one substance that helps send signals to the rest of the body to tell the rest of the body what to do with food. And what it tells the rest of the body to do is make fat rather than fuel. And that's why insulin resistance causes so much weight gain. It's also the reason why insulin resistance, which is the low end of the continuum of diabetes, is being treated with GLP-1 medications, and why diabetes medications work so well to reverse it. So the tests we look for to check for insulin resistance is a glucose tolerance test. Now, I generally like to check 1 hour glucose tolerance test. And what that is you check a blood sugar and then take a high sugar substance, a drink. Usually it's like a shot of sugar syrup. And then an hour later, check the blood sugar again. And what I always recommend is checking a free insulin at the same time, at the beginning and at the next, because it can be the change that shows that you're overshooting. And what that overshooting often is an indication of insulin resistance. The other thing that I often do is I don't start with someone fasting. In real life, I like to try and reproduce what happens naturally in our day that can cause us issues. When we eat, we've usually eaten before we've eaten. So we never walk through the day fasting all day and then we have a meal. We tend to eat throughout the meal. And if your blood sugars are slowly climbing with every single meal, it makes sense then to check a glucose tolerance test from after eating, because that's what happens. The problem is meals following each other. But that's how I do it. Many labs don't, and that's okay, because what really matters is the change from the first test to the second test. And the first test to the second test with a sugar challenge in between is really what we're trying to see what your body does when it gets challenged by carbohydrates. And so when those numbers are high, it is an indication of insulin resistance, and that can be treated. Now, there are two tests that get requested quite a bit that are really quite useless, unless under certain circumstances. One of them is being checked for cortisol. Blood tests for cortisol tell us absolutely nothing if they're normal, and not a whole lot unless they're really, really high. Our cortisol fluctuates throughout the day based on our stresses, based on just our own rhythm, our own hormonal rhythm. And so checking a spot cortisol does nothing. Generally, when we suspect there's a cortisol disease like Cushing's, which is not stress related, it is adrenal gland dysfunction, then we do what we call a 24-hour urine cortisol, and we collect urine for 24 hours and then check to see how much cortisol is in it, because that's how cortisol acts. It's up and down all day for 24 hours, and we want to see, and that's the only time we check for cortisol. So checking for cortisol doesn't help. Mainly the reason we care about cortisol is because it does cause insulin resistance. If you're under stress, you have high cortisol. If you're in menopause, you have high cortisol. If you have polycystic ovary syndrome, you have high cortisol. You don't have to check for it to know this. You just assume it, and you work to drop it. The other tests that are often requested that are really quite unnecessary are hormones, progesterone and estrogen, FSH and LH. Unless there is something specific that seems out of the ordinary for someone of a certain age, then we will check for them. But if you're looking for menopause through lab tests are normal through perimenopause. They're often normal all the way up until menopause, but you can start treating at perimenopause and with hormone replacement. And what the diagnosis is what we call a clinical diagnosis. It is based on your history that you tell your doctor and the symptoms that you're having. It's not based on lab tests. Not all chronic conditions are diagnosed through blood tests. Sometimes they're diagnosed simply by asking questions. And so asking for cortisol tests and asking for hormone replacement tests often is a waste of time and a waste of resources. And we can treat what the problem is without having to do those blood tests. So if you have any questions, now would be a good time to ask. And I'm just going to run through this one more time. So number 1, overall health, bone health, vitamin D. Number 2, thyroid disease, TSH, thyroid panel, thyroid antibodies, or reverse T3, depending on what the other 2 show. Number 3, heart disease. Risk for heart attack is number 1, what we're looking for: cholesterol panel, lipoprotein A, HSCRP, which is high sensitivity C-reactive protein, and homocysteine. Number 4, hypertension, which falls under, of course, cardiovascular disease. We look for what's called a complete metabolic panel, or a CMP, mainly to look at your renal function, but it also shows your liver function, and it also shows all your electrolytes as well. Number 5, CHF, or congestive heart failure. We look at what's called a brain natriuretic peptide, or BNP. And if it's elevated, it could be an indication that your heart muscle has been stretched. Number 6 is prostate, which is, if we're concerned about prostate disease, we check for a prostate-specific antigen. Thank you, Cindy. And so that's a PSA, and we check for that. Usually it's an annual screening also anyway, just for men, because we just watch to see. However, there are some schools of thought saying that checking too often can actually lead to unnecessary procedures on men, but that's for another day. Number 7, erectile dysfunction or low libido, erectile dysfunction in men and low libido in men and women. Check for testosterone. Number 8, type 2 diabetes is an A1C, and or hemoglobin A1C. And for insulin resistance, a glucose tolerance test and a free insulin test. Yes, I said both men and women. Both, if low libido in men and women, you check testosterone. But erectile dysfunction is only in men. We check. And so again, and then the 2 tests that really are not necessary to check because it's based on history. One is cortisol. The other is hormones for menopause. Menopause is a clinical diagnosis. Doctor, thank you for your sharing information. My question is, inositol or for what? What are you treating? Checking? Is that you're asking for if we test for it, or you think we should take it? That's Mary asking a question. Vande Dargan says, this is excellent. Sending to women I know who will listen. Oh, thank you. And I'm just going to go up. Oh, checking weight for weight management, unnecessary. We already know what causes weight gain. for weight loss unnecessary. We know weight loss is not a mystery. We know exactly what causes weight gain, and we know exactly how to make weight go away. And so checking the only time that you might check some things is if people are resistant to the normal things that we use to help people lose weight. And then you start doing other testing. But really, and if you're saying inositol, now that is a sugar substitute, is it not? If you use anything that is not naturally occurring, our body doesn't always know what to do with it. And when our body doesn't know what to do with something, it generally stores it as fat. It is always best not to use anything that is too unnatural. Now, of course, sugar is a natural substance that can cause you problems, and you don't want to eat sugar. However, using sugar substitutes, it's better to use plant-based sugar substitute, like monk fruit, and you can use alcohol sugars as well, but sometimes they actually cause the body to react as if you're eating sugar. Okay. Does muscle stretching of the heart happen with age? Not necessarily. What does happen with age, though, is our kidney function tends to go down. Our heart naturally gives off BNP. And so when our kidney function goes down, which is what pulls the BNP out of the body, that's how it's excreted from the body. If your kidney function is not working properly, your BNP can go up, and it gives a false impression of there being some heart issues. Usually when we find it high, we just do an echocardiogram to confirm whether it's your heart or whether it's your kidneys. But the heart doesn't always stretch with age. Sometimes it actually thickens with age. Sometimes it doesn't do much of anything with age. It's usually the blood vessels we worry about more with age than the muscle itself. Let me see. Why does such a beautifully made machine get so complicated? It's not really all that complicated. It's a miracle, for one. I mean, the fact that there's all these moving parts and all these moving things, and we still are alive. I think that's rather fascinating, to be honest. But we are a very beautifully made machine. I totally agree with you on that. There seems to be another comment. Oh, for satiety, thank you. Okay. We already know that the hormones that cause satiety in the body are leptin, or the levels that affect satiety are leptin and ghrelin. And so really worrying about, to be honest, I don't know a lot about them because I've never had the need to study them, because the weight loss that I help people with over the last 15 years has been successful without having to. And so I will look into it a little bit more. So all I can say is I don't have enough information to be very specific and educational on that, because I've not had to. But one of the things that does happen, and this is something to always keep in mind, weight loss is a multi-billion-dollar industry. Weight is very much a psychosocial construct. So when people are having issues with their weight, they're often targets for people who are trying to make money off of, usually the number one thing they say is, doctors won't tell you, doctors don't know, doctors don't care. And what really they mean is they don't know, and usually there's dollar signs behind all of that. So I always ask, if you're getting information, always ask why. And if there's dollar signs behind it, obviously you question it. But like I said, simple things being simple, common things being common, we already know what causes all these things, and we act on them. But that's not to say I haven't written it down, and I've written it down, and I'll double check, and I will come back and provide more information, or maybe do something on my page. But as of right now, it's not information I've really needed, but I'm always willing to learn. But thank you, because I always appreciate new information. How to lose weight with insulin resistant but not diabetic. Okay, so the way what insulin resistance is glucose dysregulation or metabolic dysregulation. There are two things that worsen and two things that help improve metabolic dysregulation. Mainly, what that is muscle, how much muscle you have, and number two, how well you manage your stress, your cortisol. And then number three, or what I like to say are like the 4 M's. So you lose weight with insulin resistance by one, focusing on your protein and fiber in your meal. So the first M is meals. The second M is mindfulness or meditation. You've got to get your cortisol level down in order for your brain not to be, because cortisol causes insulin resistance and it makes it worse if you already have it. Number three is muscle. Muscle is our powerhouse. It is our insulin, our metabolic regulator in our body. So the more muscle you have, the better you are. And then fourth is medication if needed. So insulin resistance, if it's caused by cortisol, is often caused by menopause because it leaves cortisol unopposed, or it's caused by stress, or it's caused by genetics. And so all of those things can be corrected by using hormone replacement therapy or metabolic correctors. And GLP-1s are metabolic correctors. And so that's how you lose weight with insulin resistance. It is the reason why diabetic medications work so well. Insulin resistance is here, then pre-diabetes, then diabetes, all on the same continuum. And that's why diabetes medications work so well to reverse weight gain. What causes an elevated ALP test? If you don't mind, write it out, because acronyms can mean lots of different things. Are you referring to liver? Yeah, write it out so I know, Cindy, just so I know exactly what you're talking about. Daily jerk daily, okay? Or cut out sugar out. Well, generally, when you focus on protein and you focus on fiber, yeah, I mean, when you're trying to avoid blood sugar issues, I think cutting out sugar is pretty second nature. I mean, intuitive. So you said it's liver, the ALP. Okay, so I think what you mean is ALT. Unless you're talking about alkaline phosphatase. That's why I need you to write it out, because it makes a difference as to, well, both of them, if they're liver tests, basically what elevates liver, there's lots of different things that can elevate. Okay, alkaline phosphatase. Okay. What can elevate? It's one of those non-specific tests. So not clearing it out of the body can make it go up. Bone issues can make it go up. Liver issues can make it go up. Blood vessels to the liver can make it go up. There's lots of different things, but it doesn't always mean something. Lots of times it depends on the level. Because liver failure, yes, it goes up with liver failure or liver insufficiency, but usually it's ALT and ALP that go up, or alkaline phosphatase that go up at the same time. And so really it's a non-specific test, and there's lots of different reasons why it can go up, and it doesn't always mean something. But it's always good to follow up if it's elevated. Also, something I should have said right from the beginning. When it comes to blood tests, labs allow what's called a standard deviation one way or the other. And what that means is you can go what's considered normal, and then you have the lower range of normal and the upper range of normal. If you go up about 2 ticks above normal, it will say it's high, but it's not clinically significant. And just like you can have 2 clicks below, it can say it's too low, but it's not, again, not clinically significant. Not all lab tests mean something when they say they're too high or too low in the absence of other symptoms. Sometimes it's just the lab. Sometimes it's just that time, so it really also depends not only on the results, but also on what symptoms you're having along with those results. So I often get people tell me my A1C is going up. And when I see it going up, it might be, say, a 5.5. And the next time they check it, it's 5.6. 5.5 and 5.6, when it comes to lab results, are essentially the same number. Now, if it goes up 2 or 3, that's different. If it goes from 5.5 to 5.7, 5.8, that's a different story. But 1 point, one way or the other, isn't always significant. Any other questions? All right. Well, if you don't have any more questions, I thank you for joining, and I will see you next Tuesday. If you have questions later, you can write them underneath the video. I will answer them. You can write to me at help@drtoomer.com, and I will respond. Or if you're looking to have a complete assessment and strategy and plan, I do have appointments available for that include checking for labs, going through your history. And then if medication is required, then I will prescribe, and then I do a follow-up appointment with you. Usually what it is to help you get to a point where your primary care physician isn't able to, because they simply don't have the time if they take insurance. And I do have the time, and so I just provide that service for people to kind of help jumpstart their process. And if you, again, so come back Tuesday, share this with someone if you find it's important. Tell them to subscribe to my YouTube channel. If you're listening and you haven't subscribed, please subscribe to the channel, and you can go through some of my videos. I have several on a lot of different topics, and that are hopefully helpful to you. So again, thanks for coming, and good night.